So it's now time to move to our next speaker, who is Professor Qureshi, Qureshi. So maybe some of you recognize, hello Shak, some of you recognize the next bit, the second bit of Shak balloons. So Shak is the innovator of the pediatric balloons that we've been using for decades for valvuloplasties in small babies and older children. Shak is a pioneer worldwide in transcatheter interventions, along with Eric Rosenthal, his colleague at the Evelina Children's Hospital, perforated the atrial pulmonary valves first in 1990. They pioneered fetal cardiac interventions, a number of interventions, and now in the past few years, they've pioneered transcatheter closure of sinus venosus ASDs. So he's here today with us to tell us about how this is being done and what is the experience so far with closing sinus venosus ASDs in the cath lab. Shak, very nice to have you here. Thank you so much.
Thank you very much indeed, Aphrodite. Very kind words. Not all deserved, I'm afraid, but thank you again. And I'm grateful to you and the rest of the organizing team. I don't know if you were able to see my slides. Okay. Yeah, so thank you, Aphrodite, and the organizing team for inviting me to give an update on this newish technique of transcatheter closure of sinus venosus defects. Just trying to move on. These are my disclosures, if anybody's interested. And right at the beginning, at the outset, I want to acknowledge Eric Rosenthal, my colleague, for he's been the main push in developing and forwarding this technique. And then, of course, the rest of the team, Salia Kabir is our transesophageal echo lady who's mastered this guidance of sinus venosus closure and imaging, 3D printing colleagues as well. Sinus venosus defects really have traditionally fallen into surgical treatment because they've been considered unsuitable for catheter closure. If we consider these defects as an unroofing of the pulmonary vein, such that the posterior wall of the right superior vena cava and the anterior wall of the right upper pulmonary vein are deficient, you then wonder why it took us so long to think about a catheter closure technique. But clearly, this is not as simple as secundum ASDs. As you will see here, this is a transesophageal echocardiogram showing a sinus venosus defect with superior vena cava straddling or overriding the septum here. Here are some 3D still pictures of the defect. And the point I was making about the deficiency or unroofing between the SVC and the right upper pulmonary vein, resulting in this defect and resulting in anomalous right upper pulmonary vein draining into the superior vena cava. Not going to go into surgery, of course, but surgery is a universally accepted option. The options consist of either a two-patch repair technique or a single patch or a Warden's repair. There is, depending on which technique you use, incidence of post-operative SVC stenosis and pulmonary venous stenosis and sinus node dysfunction. With the two-patch repair technique, that incidence has been reduced considerably of all the three possible problems. As far as catheter closure was concerned, it was really Hussein Abdul Wahab from Baghdad who pushed the technique and developed it with using covered stents, covered CP stents combined with ASD devices. And he reported 4 patients at the CSI Frankfurt meeting back in 2013, where 4 patients had successful closure using a variety of stents. We got interested in this, and rather than just push ahead with stenting, we developed with our physics teams and MRI and CT scanning teams 3D model prints in order to simulate what we might do. And here you can see images playing of the 3D model with a stent inside and a catheter dilator pushed from the right upper pulmonary vein into the left atrium. And then you can see that the images rotate. You can see how potentially, if you put a covered stent, it would then isolate the pulmonary vein, leave it draining into the left atrium. That led us to progress a little bit further with getting custom-made 10-zig covered CP stents because of the diameters that are involved in the SVC to put these stents. The conventional stents cannot be dilated to above 22 millimeters, and many of these superior vena cavae are bigger than that. And that development of stents requires appropriate bib balloons as well of similar diameters and lengths. Instead of 3D prints, we moved on with Fu Duong, one of our fellows, to simulation on the computer with a 3D printed model. And you can see here with a 3D model, a stent is placed inside it, and you can see the anomalous right upper pulmonary vein just draining past, unobstructed, into the left atrium. And so now we just play around with 3D models, simulation, rather than proceed with prints like this. And you can see here that once we place a stent inside the SVC covering the sinus venosus defect, how the right upper pulmonary vein is left draining into the left atrium. So the technique that we've developed involves a procedure being performed under general anesthesia, transesophageal echocardiogram assessment, access in the right internal jugular and right femoral vein, as well as femoral artery. Initially, we went retrograde arterial into the left ventricle, into the left atrium, and then tried to get into the anomalous right upper pulmonary vein through the sinus venosus defect. That used to take quite a bit of time, and so more recently we moved towards doing a transseptal technique. And here you see the catheter has gone retrograde from the ventricle into the left atrium, into the pulmonary vein. And then more recently, we've gone to transseptal technique. You can see here the advantage of this is that the sheath stays in the left atrium and a catheter through it in the pulmonary vein. And so we can measure pressures in the pulmonary vein and the left atrium simultaneously. And once we have established a circuit from the femoral vein to internal jugular vein, a balloon can be passed and inflated, and then we can do angiography in the pulmonary vein to show that there is no contrast going into the right atrium and that there's no compression of the anomalous pulmonary vein. Monitoring of the pressures in the pulmonary vein and the left atrium is obviously very important. What we found is in most cases, once we've deployed either the balloon for test occlusion or the stent itself as the last bit of the procedure, inevitably there is elevation of both the right upper pulmonary vein and the left atrial pressures, but both of them with no gradients whatsoever. And that's because of sudden cessation of left-right shunting and is related to the left atrial compliance. But it's important to spot this sort of possible complication, and that is when we inflate a balloon, there may be raised pressure in the right upper pulmonary vein, but less so in the left atrium, and there's clearly a gradient, and that suggests that there may be possibility of compression of the anomalous pulmonary vein. And here that is shown in the still pictures as well as the movie, and what we can do to prevent that. In this example, what we would do is put a balloon in the pulmonary vein to protect as you can see here in this example here. And then the stent is inflated, and that avoids or reduces the possibility of compression of the anomalous pulmonary vein. Then we use large bore sheets such as 16 to 18 French check flow Cook performer sheets, or 20 French dry seal sheets from Gore from the femoral vein. Bib balloons are made available of the appropriate diameter and length, which generally are 2 to 4 millimeters larger than the interrogating balloon diameter. 10 Zig custom-made covered CP stents from NewMed, between 6 and 8 centimeter long stents are available. And then we implant the stent such that the upper end of the stent is at the level of the azygos, or at least 2 centimeters from the SVCRA junction upwards. And the bottom end of the stent should be below the upper end of the septum, so that there's no possibility or reduced possibility of residual left-right shunt. And once we've done all that evaluation, this is a 10 Zig covered CP stent passed over a guide wire circuit in position, check angiogram from the top end through the SVC, and you can see now that the stent is quite long. We're checking for its position. There's the nominate vein at the top, there's a pulmonary vein catheter, and together with transesophageal echocardiogram guidance, we then inflate the inner balloon and then do some check angiograms before inflating the outer balloon, as you can see here. Transesophageal echocardiogram before and after. This shows an excellent result with the stent closing the residual defect completely, and that represents a good stent position. And there is no right upper pulmonary vein compression, and it drains freely into the left atrium. Because the length of the stent is important, we found, because of the possibility of migration as the stent shortens. And so we have to be prepared for that possibility. In this case, the stent slipped down into the right atrium, and using the sheath, we're re-advancing it over the guide wire circuit back into position. There's the lateral projection of that. And in order to then secure it, because it moved down for whatever reason, shortening or incorrect position, in order to secure that, we then implant a second overlapping stent from the top into the SVC, and that then secures it. And then we re-dilate the bottom end and flare it, depending on how much flaring is required. That usually is with the guidance of transesophageal echocardiogram. And here, the final position of the stent with the bottom end flared to oppose to the septum. There's another projection of the right upper pulmonary vein angiogram, which now shows predominant flow into the left atrium. And there's a small pacification of the right atrium, and so further flaring of the bottom end has to be carried out. And this shows a lateral projection with a non-compressed right upper pulmonary vein. This is how sometimes the stent has to look, with the bottom end having been flared in order to oppose it to the septum. There is a limit to how much flaring we can do, because if the bottom end needs to be more than 32 millimeters, there is a small possibility of the covering slipping off the stent, and that can then leave us with a residual left-right shunt, which then requires a second stent in order to abolish the residual flow. But you can see here in this patient, the bottom end has been flared. That resulted in a significant left to right shunt. And so another covered stent was then overlapped, especially at the bottom end, in order to abolish that residual shunt. The flaring, we have to do very carefully, but we have to then be prepared to put in an overlapping stent, as you can see here, in order to secure the previous covered stent. So Catheter closure of sinus venosus defects, first reported in at a meeting by Abdul Wahab in 2013, first reported in print in 2014 by Gaurav Garg in a 35-year-old patient with an Advanta V12 covered stent. And Jennifer Franke from Frankfurt reported patch closure using the immediate release Sidris patch in a 65-year-old patient. And then the Spanish team have reported a case a year and a half ago now, 58-year-old patient who had 2 Bentley B graft covered stents. Shiva Kumar from Chennai has experience of about now 31 cases, 8 of whom, interestingly, were less than 8 years. And there is a problem there as well. In one patient, stent migrated, needing surgery, and in another one, stent migrated, needed overlapping stent. So a pretty good experience. Our own experience, starting in March 2016 to a few months ago now, 35 patients have been successfully treated. We've focused on fully grown teenagers. So the youngest one is 15 and a half years to 73 years, weight range 64 to 83 kilos. Interestingly, bilateral SVCs were present in 10 of these patients. Right upper pulmonary vein was accessed retrogradely in 10 and transseptal in the remainder. There were a couple of patients with PFO. Covered CP stents were used of lengths 50 to 80 millimeters. More recently, we've really gone towards 7 centimeters and 8 centimeter long rather than the shorter ones. And we needed to protect the right upper pulmonary vein with a balloon in 4 patients. Balloon diameters range from 18 to 30 millimeters. A second bare stent was needed in 10 patients at the top end in the SVC, and a covered CP stent to cover the bottom end in 4 patients. And 1 patient had an Occlutech ASD device. Here are some SVC angiograms in AP and lateral projection. In this patient, interestingly, there was not only the regular anomalous pulmonary vein, but an accessory or additional right upper pulmonary vein. On check angiograms, with the balloon inflated, you could see that there was a high likelihood of compression of the right upper pulmonary vein. There's a lateral projection showing that indentation. So we put an Atlas balloon in the right upper pulmonary vein, assessed it with a balloon in the SVC, and you can see how the 2 balloons interact. We then put a covered stent in place, keeping the Atlas balloon fully inflated, and that left a little indentation in that posterior part of the stent. And the final pictures after 2 overlapping stents were that the pulmonary vein was completely unobstructed, having been protected by that balloon. What we've learned with the overlapping stents is that the longer the stent, so 8 centimeter long stent, we've only had to use 1 second stent out of the 11 patients. 7 centimeters, there were 3 out of 8, so 37.5%, and 6 centimeters, 67% of cases, there was only 1 5 centimeter long. So the longer the stents, the less likelihood there is of a second overlapping anchoring stent. At the end of the procedure, there was a residual shunt in 38% of the patients on angiography and 52% on color Doppler. By the next day, this had reduced to 21%. And I'll come back to the residual shunt in a few seconds. Complications, there were serious complications in 2 patients, one of whom developed hemopericardium, needing surgical drainage 3 days later. And there were no other tears or anything, and it was thought that this was related to the transseptal puncture causing the hemopericardium. And 1 stent embolized 6 hours after the procedure. The others were manageable, less serious complications: femoral artery pseudoaneurysm requiring a thrombin injection, neuropraxia, arm neuropraxia in 1, atrial fibrillation needing cardioversion in 1. This is an example of a patient in whom we should have put a second overlapping stent, because on flaring you can see there's only a small segment in the SVC and the rest was in the right atrium, but we didn't, and so that was an error, because 6 hours later the stent embolized to the right ventricle and was removed easily at operation when the repair was carried out. And that during the follow-up, ranging from 3 months to around 4.5 years, what we see is there has been symptomatic improvement in all the patients. CT scans have been performed in 22 of the patients, usually about 3 months after the procedure. And these have shown excellent results with good patency of the stent and unobstructed unobstructed right upper anomalous pulmonary vein draining now to the left atrium. MRIs have really been quite interesting in that end-diastolic volume has reduced from a mean of 150 mils down to mean of 96 mils per meter squared, showing remodeling of the right ventricle. There have been no late complications. There was sinus rhythm with no sinus, no dysfunction in any of the patients on Holter monitoring. There was no significant residual shunt except in one patient who has a significant anomalous additional right upper pulmonary vein, because there are some patients in whom there may be more than one anomalous pulmonary vein. So to conclude, catheter closure of sinus venosus ASDs avoids surgery-related morbidity. It avoids risks of postoperative stenoses and sinus node dysfunction. It does produce, in our experience, good results equivalent to surgery. Stent migration can be reduced with anchoring additional stents. It is a word of caution. It is too early to recommend this wider application in children who have not reached their growth potential, although that has been done certainly in Chennai in 8 patients who were less than 8 years of age. But there is some uncertainty about what will happen 10 years down the line. But in all patients who are anatomically suitable candidates, transcatheter closure of the sinus venosus defects should be performed. Thank you very much indeed, everybody, and Aphrodite. Keep safe and well.
Thank you, Shak, for an outstanding talk and excellent results.